This graph plots two competing trajectories in Aruba's healthcare system: the relatively stable capacity of the AZV budget and the steep, accelerating rise of the population aged 65 and older. Right now, these two lines are converging into a severe mathematical pinch point. The Allgemeine Ziektekostenversicherung is a single-payer system, legally anchored in 1992. But its original architecture was designed almost entirely for curative intervention, treating patients only after they become ill. As the population ages, the prevalence of non-communicable diseases like diabetes, hypertension, and cardiovascular conditions multiplies. Treating these complex chronic conditions in their late stages require intensive hospital resources. The cost of that reactive treatment is now vastly outpacing the system's foundational 9% premium base and government subsidies. Temporary budget cuts simply delay the math. To survive, the AZV must structurally re-engineer its architecture to integrate comprehensive preventive care, backed by legislation and driven by predictive data. We can identify exactly where the capital leaks by looking at the system's structural baseline. The basic package legally guarantees payment for specialists and hospital interventions, but it specifically omits comprehensive general checkups, vision care, and mental health screenings. Because the system lacks a primary prevention net, patients remain clinically invisible. They pass straight through the early stages of illness and hit the system only when their conditions reach an acute, highly expensive phase. An architecture built purely for curation maximizes financial extraction from the fund because it exclusively engages patients at their highest level of acuity. In response to pandemic-era pressures, Aruba implemented the Mehrjahren Financial Kader, or MFK. This fiscal framework was designed as a structural cost containment tool to replace temporary ad hoc cuts. On a fiscal level, the MFK works. In 2024, it kept the system 15 million florins under budget. But it has a strict limitation. It controls money leaving the system, doing nothing to reduce the underlying disease burden driving demand. Older migrants and a growing domestic senior base guarantee that clinical volume will continue to rise, regardless of where the budget cap is drawn. Applying a rigid financial ceiling over an unmanaged growing disease burden creates mathematical friction. Eventually, it forces care rationing, unless the clinical risk is intercepted upstream. Relieving that upward pressure requires injecting a new, permanent preventive layer directly into the system architecture. This cannot be achieved through optional public health campaigns. It requires explicit amendments to the AZV Act to make preventive services legally mandatory. These statutory additions must decide specific standards of care, including mandatory adult vaccinations, targeted cancer screenings, and clinical lifestyle counseling. To execute this, the legislation must also establish a dedicated preventative care fund with a protected line item within the AZV budget. Codifying these services into law is the only mechanism that firewalls preventative investments. It ensures they aren't cannibalized the next time acute hospital expenditures spike. Even with legal mandates, the current fee-for-service model creates an economic headwind. Providers are financially rewarded for processing sickness, not preventing it. This flowchart contrasts fee-for-service with capitation. Instead of paying per medical event, capitation provides steady funding to primary care clinics based on patient population. With shared savings, doctors achieving early disease detection earn a portion of the hospital savings back as performance bonuses. This inverts the clinical economy, rewarding providers for health maintenance rather than illness extraction. Managing the preventative health of over 100,000 people requires more than static clinical databases. It requires the ability to track thousands of shifting variables across the entire population simultaneously, catching risks the moment they emerge. To effectively scale this preventative layer, the AZV can use predictive artificial intelligence as a powerful primary multiplier. AI processes electronic health records and social determinants in real time. These algorithms predict who is at high risk for chronic disease before symptoms manifest. Once flagged, predictive alerts route patients away from the high-cost curative pipeline and into early intervention screening. Global benchmarks prove this works. The UK's National Health Service uses predictive models to manage admissions, and tools like DeepMind operate at high accuracy and early cancer detection. AI acts as an automated triage mechanism, identifying clinical risk in the data phase so it can be neutralized before it materializes as a financial or physical liability. Sustainability only happens when the legal, financial, and analytical layers of the AZV are locked into a single strategy. Isolated public health campaigns cannot fix a system built for reactive care. Securing the AZV requires 3 interlocking steps: amending the law for legal mandates, restructuring provider reimbursement through capitation, and deploying predictive AI to manage population risk. In 1996 and 1997, Aruba executed a massive physical integration, absorbing disparate industrial and government funds into a unified AZV structure. Just as the system united those fragmented programs 30 years ago, it must now unite clinical care with predictive data. By transitioning from a reactive payer of sickness to a proactive guarantor of health, Aruba can secure the AZV's financial integrity and protect universal coverage for generations to come.